Good morning, good afternoon. It is in fact good afternoon, and for those who watch this in delay, potentially good evening. I'm Eric Vinkier, and I will share this webinar. The webinar is on big data and healthcare. So the Institute and Faculty of Actuaries has, over the past 4 years, ran a major project on big data and healthcare that is sort of, interesting for itself, because of course we work with insurers and pension funds on matters of healthcare and mortality and morbidity and longevity, but also as a sample project as to what you can do with data science in the actuarial sciences. So here we are going to have a webinar with a video of about 1 hour, a rough hour, and an opportunity after that with a panel of about 20 minutes, 25 minutes to get your questions answered. Let me quickly introduce everybody that you will see today. I'm Eric Vinkier. I have been the past 3 years chair of the Institute and Faculty's Research and Thought Leadership Board, as it was called. This board also had overview of the Actuarial Research Center. The Actuarial Research Center is a vehicle for the Institute and Faculty to manage and implement longer lasting research projects that often incorporate academic input. And this was one of these projects managed through the Actuarial Research Center. You will see Professor Yelena Kulinskaya, who has been the principal investigator for this project. She is professor at the University of East Anglia at the School of Computing Sciences, and she has been all her life a statistician. She has worked on topics of medical statistics, but also on topics of insurance statistics, and therefore was the ideal fill for this project on big data and healthcare. You will hear from 3 of her PhD students, Padma Chutto, Njabelo Nkube, and Nurunahar Akhtar. They are all 3 towards the end of their project. They are advanced and will show you what they have achieved over the past 3 years. Also, we will see Ilyas Bakbergenuli, postdoctoral researcher, so a postdoc at the University of East Anglia, and in particular, he has worked on the IT side and the IT implementation, and will show some of the work in R, a very popular programming language for practicing actuaries. And then Yelena will sort of round out the presentational part, and then we head straight into the panel. For the panel, we have Professor Nicholas Steele, a medical practitioner at the Norwich Medical School, also of University of East Anglia, and he is also professor in public health. And we will also have one of our members of the Institute and Faculty of Actuaries, namely Nigel Wright. Nigel Wright has, an extensive career as practicing actuary, and is working at Aviva, and at Aviva he heads the life data science and the healthcare data science work that Aviva is doing. So we're going to have the webinar about a good hour in video, and then 20 minutes in question and answers. You have on your screen a question and answer box, and I invite you to fill that question and answer box with your questions immediately as they pop up in your mind. So don't wait until the end. Just field, live stream the questions to me as they pop up in your mind. I will collect all of them and we'll get them answered. Those that cannot be answered during the panel for lack of time, we will answer offline, but we will distribute a write-up, which will then also answer the questions for which we might not have time as well. If you have technical issues, there is also a chat box, and the chat box is followed up by Walid Solima. Walid manages webinars for us, and he will try and help you promptly during the webinar itself. So sound not clear, video not coming through quickly enough, whatever technical issue you might have with the webinar, put that in the chat box. Put your questions in the Q&A box, put your technical issues in the chat box, and Walid will try and help you with the technical issues promptly. I will collect all of your questions and field them to the panel at the end. Obviously, as a member of the Institute, you are requested to record during the year your CPD, your professional development. It speaks for itself that this webinar is an absolutely suitable topic to collect for your professional development record. So here we go, presentations about an hour. I hand over to Yelena Kulinskaya, please.
Good afternoon. I'm Elena Kulinskaya. I'm principal investigator on an AFC-funded research program on using big health and actuarial data for modeling longevity and morbidity risks. And today I'm going to talk to you about the last 4 years, what we have achieved in our program. But first of all, let me share my screen with you. Okay, you can see that we have quite a large team working on this research program, and you will hear from all the people listed here. I'm here to provide an introduction, explain some heavyweight statistical methods we developed for this program, and then I will pass on to other team members who will tell you about their research into particular medical conditions and also about our software. This is the contents of my talk. As I said, after a quick introduction, I will tell you about the technical part of the methods we developed to interpret the results of big data analysis. And then you see those 4 talks which will follow on various health conditions. And then I'll be back with summary and discussion. The aims of our research program is the development of novel statistical and actuarial methods for modeling mortality and morbidity and evaluating longevity improvement based on big health and actuarial data. Our research program is uses so-called the Health Improvement Network, or SIN, primary care data. SIN is a pretty large database of UK primary care records. It covers about 7% of the UK population, and it is considered representative of the UK population given adjustment for socio-demographic factors. Our subset of SIN includes all patients who were born before 1960 and followed up to January 2017, which is 3.5 million patients. We selected this subset because we wanted to work with somewhat older population to be able to evaluate longevity more precisely. The advantage of using individual level medical data is that it is possible to model simultaneously the uptake of medical treatments and the effect of the treatment on longevity given individual lifestyle and health factors instead of the aggregated performance. This is a snapshot of our website, and you can see quite a few conditions and interventions we were working on, and today we will hear about our research on the survival benefits of statins and also stroke and GA, diabetes, and HRT. Now I'll move into the technical part. Of course, we all know what are the hazards. Here there is some discrepancy between statistical language and the terminology of the actuaries. Statisticians usually use the word hazard, whereas actuaries are talking about force of mortality and mortality intensity. But the sense is exactly the same. Hazard is an instantaneous failure rate and time, or HD, or in other words, is the probability that an individual will experience an event in time t, given that that event has not yet happened before time t. I tried to draw a couple of different shaped hazards here. This is a constant hazard over time, and this is kind of a pasta shaped hazards, but it doesn't really matter. It's a Cox regression is a type of survival modeling which is used in medicine and health sciences almost by default. Everyone is using only this model practically. The Cox model estimates the hazard or force of mortality mu I at time t for subject I by multiplying the baseline hazard, denoted here by mu naught, by the subject's risk score, RR. So basically, Cox model assumes that the hazard can be factorized into two separate terms. The first term is the baseline hazard. It depends on time, but it doesn't depend on any covariates, any predictors. And then the risk score does depend on covariates, but it doesn't depend on time at all. Usually, this risk score is written in a linear form. So on a log scale, we'll get a standard regression equation here. As we see, the risk factors that have log linear contribution to the force of mortality, and importantly, this contribution does not depend on time. So this, of course, is pretty strong assumption used in the Cox regression. Because of this factorization, if you look at the hazard ratio of hazards between subject I and, say, subject J, this baseline hazard will just cancel. And what will be left will be a part which doesn't depend on time at all. So the hazard ratio is constant over time. It's time independent. So I tried here to draw how those hazards would look. Here are the constant hazards for men and women, but what is important is that the ratio of the hazards is constant. It's 2 across the time. Here, this is plot on the log scale. So once more, this is hazard for smokers and for non-smokers, and they just differ by a constant on a log scale, which once more will translate into constant hazard ratio on the original scale. I will return to this pretty strong assumption of the Cox regression very soon. But for now, I want to talk about a different issue with the Cox regression, and that is the baseline hazard. The actuaries always would need to know the baseline hazard, because without the baseline hazard, we won't be able to estimate, say, survival or cumulative hazard or life expectancy. So we would need to add the baseline hazard to our survival analysis model. And it is well accepted that Gompertz distribution provides a good description of human mortality between ages 50 and 95. Also, Gompertz distribution is very, very simple. The hazards on the log scale are just straight lines with intercept A and slope B. Here, for instance, we have fitted Gompertz distribution to life table, period life table back from 2010, published by the Office of National Statistics. And you can see that we do have 2 straight lines for men and for women on the log scale. So the Gompertz distribution describes the hazards in the English population pretty well. Because of this, we pretty often use Gompertz baseline hazards combined with the hazard ratios of the Cox regression. Of course, there is no need necessarily use the Gompertz baseline hazards unless they fit. We can just as well use, say, viable hazards, which we do in some of the particular conditions we'll tell you about later. So now, what will happen if the proportional hazard assumption is not met, which happens actually pretty often? For a Cox model, we can use 2 different ways to cope with non-proportional hazards. A first way, which I am going to talk about, is a so-called landmark analysis. And this is an analysis which amalgamates a smooth series of piecewise constant hazards obtained from a series of Cox regressions. I will explain more on the next slide. This is a comparatively new statistical method which was published the first time in the paper by Van Groningen and Gutenberg in 2011, and it became very popular in medicine and biostatistics since then. Another method I am going to talk about today is a model which we developed ourselves, and this is, at least we call it the Double-Cox model. This model allows model both shape and scale of the baseline hazards. I will tell you about it later as well. But now, landmark analysis. Okay, so to put it in more details, landmark analysis accounts for time-dependent effects by fitting a series of Cox regression models within a sliding window. So we have a series of landmark points, S, which can be quite a large number, say 30 or 50 points or 100, just as well. And we are sliding a window of width W along the time or age scale. In each consecutive window, we have a data set which is obtained by truncation at landmark point TLM and administrative censoring at the end of the window, TLM plus W. So we are using information on all the patients who are still alive just prior to TLM, and we censor them out at the end of the window. And within each of those windows, we fit standard Cox regression, which is an equation up here. So basically, what is important here is that the coefficients of this Cox regression depend on the landmark point we have chosen. They are estimated here. They are constant within this window. When we move to the next window, we have a new set of coefficients for the next landmark point. So in principle, we would get quite a jumpy sequence of coefficients, but then we would smooth it using polynomial smoothing. A bit more detailed with it. For now, let's see how we use landmark analysis. We wanted to look at the survival benefits of statins. We have chosen 110,000 of patients who turned 60 between 1990 and 2000 and didn't have a previous statin prescription or cardiovascular diagnosis. We have chosen 51 landmark points from age 60 to age 85 every 6 months. And we will update medical history of those patients at every landmark point, every 6 months, until the end of follow-up, which could be for individual patient death, moving to some other practice, or the end of the study. Because at 60, people are pretty much healthy, majority of them, we have quite a few missing data values, especially at the start of our time span. And because of that, we used multivariate multiple imputation at age 60. After that, we have done landmark analysis on the imputed data. So we fitted Cox proportional Hurdle regression for all-cause mortality at each landmark point from age 60 to 85, as I mentioned, 51 landmark points. And our model was adjusted for medical system. And then we smoothed those 51 regression coefficients using actually third-degree polynomials over time. And coefficients of those polynomials can be estimated using pseudo-partial light. So this is the smooth hazard ratios we obtained. Those particular ones are for the use of statins as compared to non-statins. As you see, we have here two different curves for two different subpopulations. The top black one is for people born in 1930 to 35, and the lower red one is for people born between 1936 and 40. So you can see that people born 5 years later seem to have better benefits of the statin use. And also what is interesting here is that for both those cohorts, the benefits of statin use actually increase with the advance in age. So this is quite an interesting conclusion that the elderly would benefit greatly from the use of statins, which is still rather controversial because sometimes elderly people are not prescribed statins because GPs are worried about multi-pharmacy. But anyway, because this is an important finding, we published this paper in a medical journal. Now, what we also wanted to do, because we didn't only look at the use of statins, we adjusted this model for quite a few other health variables. We wanted to use the results to calculate life expectancy for different risk profiles. So we looked at statin use, smoking, hypertension, diabetes, hypercholesterolemia or high cholesterol, BMI category, and cardiac risk category. This gives us 648 combinations in total. We also separated the life tables by gender and by quintile of the social economic status. So we got 6,480 different risk profiles. And we estimated prevalences of those risk profiles at 51 Gompertz points. Why did we want to do that? Basically, because we looked at the overall survival as given by ONS for particular year and particular age. And we used those weights which are coming from the prevalences to calibrate our survival functions at each age and at each landmark point. So basically, after we have done this, we were able to obtain life expectancies for each risk profile. And we implemented this methodology described in our publications in insurance mathematics and economics to provide longevity up for general public. This app, as you see, allows people to enter their demographic characteristics and also their various health conditions, which are part of our model. And they can calculate their average life expectancy. This app proved to be pretty popular. More than 200,000 people so far have used it. And we also use this way to estimate life expectancy in our R software, of which you will see later. The second method I'm going to tell you about is this parametric double-Cox regression. This seems to be a pretty busy slide, but I'll talk you through it. We'll start from this Cox regression formula. You recognize the baseline hazard here and this part is a standard Fox regression. So this part is a model for scale of our distribution. Beta here is a vector of unknown scale parameters, and that is a vector for parameters. This is what we usually get from the Cox regression. Now, this part is a baseline hazard. And in this model, we would use either variable or Gompertz baseline hazard function. This baseline hazard function, each of them, has two parameters: scale, mu, and shape k. And we are modeling the shape of those distributions as a function of variance in this log linear form. So basically, this is a second Cox model for shape, which we are adding to the baseline hazard. That's why we call this model Double-Cox. Finally, we have this term U, which is called the frailty term. In fact, this is just a random effect, which has gamma distribution with mean 1 and variance sigma squared, which is used to model heterogeneity in the population. The variance of this random term reflects the heterogeneity. But what we usually do, we use it as so-called shared frailty, so that those random effects differ by cluster. And a cluster may be, for instance, a GP practice. So patients in each GP practice are similar in some way. And that's the term they all share. This random frailty would have something J for the chase. GP practice. We can also use it, say, as a shared frailty for a particular company, if we're talking about insurance company and its clients. So this is our parametric Double-Cox regression. To explain better what it allows us to do, I borrowed a slide from our type 2 diabetes model. This axis Y is a log cumulative hazard, and this is follow-up time in years. You can see here survival log hazard curves for 3 birth cohorts. This is 39 to 40, 30 to 39, 40 to 49, and 50 to 1960. As you can see, the older the birth cohort is, the higher are the hazards, just reflecting mortality improvement over time. And this mortality improvement can be seen from the intercept of those log hazard lines. And this is a scale in our Cox regression. Now, those hazards actually also have different slopes, and different slopes come from modeling shape of those hazards. You can see once more that for the oldest cohort, the hazard goes up more steeply than for younger birth cohort. Finally, there is another effect, which is effect of diabetes diagnosis at particular age. And you can see that those curves are parallel. For instance, here you can see that the solid line is a diabetes in a person's 50s. And the lower line is a hazard for people who are diagnosed with diabetes later, after age 60. So those two lines seem to be different only by scale or intercept here. There is no shape effect of diabetes at this point. So I hope that I explained how the Double-Cox model works, and you will hear more about those Double-Cox models, both with variable and with with Gompertz hazards in the subsequent talks. So this is it. I am now passing the mic to Padma Tutor, our first PhD student, who is doing the PhD on the survival modeling of stroke and TIA. And I will join you once more for summary and discussion. Thank you. This is our references, which contain both our methodology, references 2, 3, and 4, and also our actual findings on statins, references 1 and 5. And absolutely.
Hello everyone, my name is Padma Tutor, and today I'm going to present on stroke mortality and morbidity in the UK. So I'm going to explain on the different types of stroke that we've considered for the studies, the important model findings, and we are going to see how these types of stroke affect life expectancy. First of all, what is stroke? Well, stroke is when the brain is starved of oxygen due to clots or bleeding. Now, the first type of stroke, which is caused by clots, is called ischemic stroke, and is the most famous one, occurring in 85% of the cases. Whereas hemorrhagic stroke occurs in 15% of the cases. Now, sometimes these clots may cause a temporary neurological disturbance, which means that the symptoms just appear temporary. And such type of stroke is called transient ischemic attacks, or TIAs, or mini stroke. Now, they should be taken quite seriously because they serve as warning sign for future strokes. Now, stroke is a serious medical condition. It's good to know that cerebrovascular disease is among the 3 topmost leading causes of death in UK. And stroke account for 75% of death of cerebrovascular diseases. Unfortunately, stroke is also the leading cause of disability in UK. Stroke prevalence is projected to rise, as well with its associated costs. We studied the impact of the first ischemic stroke and TIA on longevity and morbidity risk. Our study spanned from 1986 to 2017, and we aimed to match a case to at least 3 controls. We excluded life-limiting condition, and our primary outcome was all-cause mortality. We adjusted our model with different variables based on the stroke literature. For example, some drugs, important medical conditions, demographical, and lifestyle conditions. Let's have a look at the important findings from the study of survival of the TIA. Well, we found that patients born in later cohort fared better than their counterparts born in earlier cohorts. We also found that aspirin was providing long-term survival benefits to TIA patients and was not favorable, unfortunately, to controls. We also noticed that TIA patient had a high burden of cardiovascular comorbidities such as atrial fibrillation, hypertension, compared to their matched control. And also, the risk of death of TIA patients were more than the matched control, even after 10 to 15 years of the first event. Now let's have a look at this findings of survival of the ischemic stroke. We found that antiplatelet were providing a survival benefit to all types of patients across different birth cohorts and genders. We also found that survival outcome in England improved over time. So we plotted the 1 year, 1 month, and 3 months fatality after stroke, and we noticed a major improvement post-year 2008. And why is that? This is because NICE recommendations were implemented, which included mandatory administration of important medications, surgery, imaging, and rehabilitation. We also noticed a rise in the prescription of medication for stroke patients. However, we noticed a decline of antiplatelet in the year 2010. Yet our findings showed that antiplatelet provided a survival benefit. We also performed models of life expectancy given these neurological conditions. For example, in this table, we can observe that a male diagnosed of ischemic stroke at age 50 after 2 years have passed will approximately use 14 years of his life, whereas a male diagnosed of TIA at age 50 and again 2 years have passed will roughly lose 7 years of his lifetime. There are more examples of different age diagnoses in this table that you can see the different number of years lost. So these were the important references for our presentation. I thank you for your kind attention. Thank you.
A good day to everyone. My name is Jablon Lube. I'm a postgraduate researcher at the University of East Anglia. My research is focused on modeling the survival of type 2 diabetic mellitus individuals in the United Kingdom. My presentation is going to follow the following outline. I'm going to give a brief introduction and a glimpse of our study population and the statistical methodology that we use. And then after, I'll present the results and then share with you the application that we are currently developing. And thereafter, I'll give back to the moderator for the next sessions on question and answer. The objective is to estimate the survival of diabetic mellitus individuals in the UK using the big health data, and we use the thin database. Our study is a retrospective matched case control study, and we selected individuals who were born between 1930 and 1960 inclusive. Of these, we selected those who were diagnosed with type 2 diabetes between 2000 and 2016. Diagnosed at the ages between 50 to 74 years and had no serious medical conditions at the time of diagnosis. The conditions that we excluded include stroke, dementia, cancer, and any serious conditions of heart failure, myocardial infarction, atrial fibrillation, and PVD. Of the diabetic mellitus individuals that we selected, we then matched them using 1:3 ratio by general practice, gender, and age. We managed to get 221,182 individuals in total. Of these, 29,618 died during the follow-up period from 2000 to 2016 inclusive. And we can see that the prevalence of those diagnosed with type 2 diabetes increased with increase in time. You can see that in 2004, it was on average 20%, and it increased to on average 35% in 2010 to 2016, which is showing the trend of an increase in the prevalence of diabetes. And our population was mainly made up of males, and those aged 60 to 74 years inclusive. Like any other administrative database, we did have issues with data capture. We had 6.1% of our study sample missing smoking status, 15.8% yet missing BMI values, and 6.6% yet missing social economic status, the TDI. We made a use of Began et al. Model that is suggested in the paper published in 2019. And in our case, the Gompertz was a better fit for our data. So we used the Gompertz-Cax model, which had a gamma frailty. We'll then use the complete case. By complete case, I mean all the individuals we had all the values in every variable that we selected. And then we use backward elimination for variable selection, using 5% for main effects at the significance level and 1% for interactions. For the variables with missing values, we used a joint multiple imputation method to do our multiple imputation, using a JOMO package in R. We use the coefficient of concordance, negative likelihood, and AIC for us to select the best model. And in particular, in our case, the imputed data model had a coefficient of concordance of 0.76. The Began et al. Model does allow for time-varying effects. And in our case, we had the birth cohort, atrial fibrillation, and hypertension having significant time-varying effects. Of the time-invariant effects, we can see that from our results that being diagnosed with type 2 diabetes at an early age increases mortality risk compared to being diagnosed in later years. And also that being a smoker triples the risk of mortality, and being diagnosed with hypercholesteremia and not taking any medication increased the mortality risk by 41.2%. This result plot B, it shows for the birth cohorts time variant variable. We can see that those born in earlier years, they've got higher risk. Generally, that's the norm because time on its own is an independent factor when it comes to mortality. But however, we of interest is the comparison between the 1940 to 1949 and the 1950 to 1960. We can generally see that the slope of the 1950 to 1960 is higher than the slope for the 1940 to 1949, which shows that with pass of the time, it might be possible that they might have a mortality that would be higher than the 1940 to 1949. Generally, what is being presented here that they've got a very poor mortality experience compared to the 1940 to 1949, in as much as it's lower, but the slope on its own it shows it's a cause of concern. However, on its own, it's not conclusive because our time ends in 1960. It will be probably for further research to have those who were born after 1960 and see their mortality trends and compare and see if they have got a better mortality than these in terms of the experience or in terms of the slope of their hazard functions. We then use our model to compute life expectancies for individuals with given conditions. From our model, we found out that the life limit, the age limit was 100 years. When you're saying age limit, does not mean that that's the life expectancy. We then use the age as a time scale. The model that we use for calculating life expectancy uses age as a time scale. And the app does provide plots of hazard, cumulative, and survival functions. And also it does present a table of life expectancy for an individual. And then for the hazard and cumulative hazard functions, one can plot them or present them at the log scale. I would like to share with you the Shiny app. However, please take note, this has been published for the purpose of this presentation. And after this presentation, it won't be accessible until it has been fully developed. As you can see, this is the application. The first inputs controls are basically for the plots, where one chooses whether they would want a hazard or cumulative hazard or survival function. And then for the hazard or cumulative hazard, they can specify if they would want it to be at log scale. And these are the characteristics of the individual. One can just make selections here, 1930 to 1939, can select the birth cohort, and then the ages. Once one selects the birth cohort, the age also changes here and specifies the range of ages that are expected that a person born in that age group. Let's look at those born in 1930 to 1939, for example. This is for the born 1930 to 1939, a person being diagnosed at age 60, but in this case, the person is not diabetic. So let's specify that the person is diabetic here. So the person is not diabetic, but was age 60 at the time of selection into the entry, into the study. And you can see this gray broken line is just for comparison, just trying to compare the person with the characteristics that you have been given, and it's for the baseline population. This is for the baseline population, so that you can just have a comparison on how far it moves from the baseline function. So one can specify the cumulative hazard, and one can specify if it's just to plot it not at log scale, and one can specify whether it's a survival function. One by one changing the variable, it also adjusts in if one is a male, it also adjusts this accordingly. The next tab shows the summary of the parameters that are used to calculate or to plot the function and calculate the life expectancy. We can see that this person is 60, diagnosed with type 2 diabetes, and with a smoker, and also is of overweight, BMI class, and all these other conditions or characteristics would be expected to live 23.5 years after being diagnosed at 60. And this table, it does show the life expectancy of that person at 60. That person will be expected to live 23.5 years. And then, given that the person survives to 61 years, the person will be expected to live 22.71 years. That is all with the Shiny app. And thank you so much for listening.
Hello everyone, I am Nurul Nahar Akhtar. Today I am presenting a summary of my 3.5 years work on the project, the use of big health and actuarial data for understanding longevity and morbidity risk, which is funded by the Actuarial Research Center of the Institute and Faculty of Actuaries. And the topic of my talk is the effect of HRT on the survival of UK women. This slide is about hormone replacement therapy, HRT, and its use. Around 80% women in the Western countries suffer from menopausal symptoms. HRT is mainly used to treat menopausal symptoms caused by deficiency of female sex hormones, estrogen and progesterone. It was first available in the United Kingdom in 1965. There are different routes of administration of HRT, such as oral tablets, transdermal patches, injections, topical gels, and ointments. In this matched cohort study, cases are the patients who prescribed any kind of oral and or transdermal HRT at age 46 years or above. Outcome is death from any cause after starting HRT. We excluded patients with any kind of cancer, acute myocardial infarction, serious heart failure, stroke, chronic kidney disease, stage 3 to 5, dementia, oophorectomy before 45 years, premature ovarian insufficiency, premature menopause, and surgically induced menopause to estimate the effect of HRT on healthy postmenopausal women. Our analysis included 105,199 cases who born between 1921 to 1960 and started HRT between 46 to 65 years of age, and 224,643 matched controls. Length of follow-up was up to 32 years between 1984 to 2017. A Cox proportional hazards module was fitted by adjusting important medical, socio-demographic, and lifestyle variables, and the significant covariates were selected by backward elimination techniques, and the final model covariates included are type of HRT, birth cohort, age at HRT, deprivation status, hypertension and its treatments, coronary heart disease, uterine ovarian status, interaction of smoking with body mass index, and smoking with type 2 diabetes. Incomplete records in BMI, smoking, deprivation status, systolic, diastolic blood pressure were dealt with by multi-level multiple imputation using the JOMO package in R programming software. The proportional hazards assumptions were checked by Grunch and Thurnio test, and it was found that birth cohort and age category at study entry violated the PS assumptions. Thus, we fitted a parametric double-cox model that estimates the shape parameters for the variables with time-variant hazards based on the underlying baseline hazards of the study population. By fitting the baseline hazards of our study population, which is shown in black color with test confidence intervals with different parametric distributions, and calculating the AIC, we identify that our population fits best with the Weibull distribution, and hence a Weibull double-cox model was fitted to handle the non-proportional hazards. This slide shows the survival curves of 4 different age groups by HRT type for 4 birth cohorts. Different color indicating different age group at first treatment. Dashed line represent the combined HRT users, dotted lines are for the estrogenol users, and solid lines used for the non-users. The time is in years from the study entry. The survival plots show that combined HRT users survives longer compared to the non-users in all age group at starting HRT. And early combined HRT starters have greater survival prospects. Survival prospects also increases in later birth cohorts than the earlier. We also performed subgroup analysis to estimate the effect of age-specific HRT on the hazards of all-cause mortality. The first plot shows the adjusted hazards of mortality associated with HRT for full data and age subgroup analysis. Overall, there was no effect of estrogen-only HRT on women's survival, but combined HRT reduces mortality by 9%. When analyzed by subgroups, it was found that highest reduction was in women who started treatment at age 51 to 55 years, and no significant reduction in combined HRT users of age group 46 to 50 at first treatment. Currently, we are developing a survival model with age at a time scale, which will be used to calculate the life expectancy of women population in the UK. Thank you.
Hello everyone, my name is İlyas Bakpergenoglu and I'm a postdoctoral researcher at the University of East Anglia. My research is being funded by the Actuarial Research Center under the research program The Use of Big Health and Actuarial Data for Understanding Longevity and Morbidity Risks. And today I'm gonna talk to you about our R software that we have developed during our research. The main objectives of my talk is to introduce R package, my longevity, for calculation of life expectancies, functions using standard Cox regression and results from landmark analysis, functions using Double-Cox parametric survival model, and I'm going to also give you an example of using one of the functions inside our R package. In the end, I will summarize my talk, and if you have any questions, please feel free to ask them. So the R package, my longevity, is available in GitHub repository, and in order to install it, first you need to install RTools software, and then you have to install a package DevTools. After that, you can use the command given in second line, and our package should be available to you. Our package consists of 5 main functions, and I'm going to go through these functions one by one. So the first function is called myLongevityMethod1. It is a function that has 3 parameters, and 3 parameters here are the data, which stands for datasets, index of variables, which you should specify which columns you want to use in this function, and working directory. What this function does is this function matches the attributes of inputted data with the results of life expectancies obtained from the landmark analysis. After that, for a set of given attributes, this method produces a table with life expectancies at a given age, similar to those we have provided in our website, mylongevity.org. In second function, myLongevityMethod2, it is quite similar to function 1, however, this function does not use the weights from our research. So what I mean by that is basically this function uses the log hazard ratio estimates from landmark analysis that we have done, and the weights are calculated from the inputted dataset. So in parameters of these functions, you see some additional parameters such as list of variables, which corresponds to the names of variables which you want to use, age of interest, A and B. A and B are the shape and scale parameters supplied by user, and working directory is still a working directory which you want to work on. And the weights here correspond to frequencies of risk profiles in dataset. In myLongevityMethod3, it is different from myLongevityMethod1 and myLongevityMethod2, by the following. So here basically you fit your Cox regression to the provided data and eliminate the non-significant terms. After that, the function calculates weights for each combination of risk factors in the final Cox regression model and computes life expectancies based on our methodology. So here A and B are still the Gompertz shape and scale parameters which have to be specified by a user. You see some additional free parameters which is T-start, T-stop and T-status indicator, and these are the same as in the standard Cox regression model. So, and this model is available in survival package. So here is the example of the data entry. So we have age, which is number of years from your birth, gender, males or females, Townsend is the deprivation index, smoking category, HTN stands for hypertension status, so you can have no hypertension, treated hypertension or untreated hypertension. Diabetes category 0 or 1, HCl stands for hypercholesteremia status, BMI category is BMI. So then Q risk is a cardiac risk calculated by Q risk 2 calculator, and intake of statin indicator. So it's a 0 and 1 for yes or no statins. So here is the example of 10 individuals in our dataset. So for example, you have 10 individuals for different ages and gender, Townsend and smoking categories and so on. So in the first lines, in the first columns, you see the categories. So these are the different combinations. And then in last three columns, you see A, B, which stands for shape and scale parameter of Gompertz distribution for each combination, and life expectancy for each combination of risk profiles. So next we are going to talk about two more functions which will be available in our package, which are Double-Cox longevity 1 and Double-Cox longevity 2. So these methods fit Double-Cox parametric survival regression model and calculate life expectancies based on given parameters for either Gompertz or weighable baseline risk. Here are the parameters you should specify in these functions. So data is still a data set. Dist is a distribution, which can be either Gompertz or weighable. Cluster is a membership variable for share frailty. Formula shape and formula scale are the scale and shape parameterization. So you should specify your survival models here. Age of diagnosis is the age of diagnosis for a particular condition. Time passed from diagnosis. So if you want to estimate life expectancy at age of diagnosis, time passed from diagnosis should be 0. Otherwise, you can estimate life expectancy some years after the age of diagnosis. Working directory, and we have a factor name for age factor, which is a particular setting in our function you can use in order to calculate life expectancy. So sometimes if you want to include an age variable as a continuous variable in your scale parameter, you should specify the name of this factor, and otherwise default is null, and the life expectancies are calculated by standard Gompertz and weighable distributions. So the functions in my longevity package can be applied to dataset of interest in order to provide survival analysis and calculate life expectancies. And these are based on our research. The functions can be either applied with our existing models and results, or to develop new survival models from scratch. The package will be available in GitHub. Thank you for your attention.
Good afternoon once more. Now I'm here to summarize our findings and also to discuss various issues to do with observation of data. Here. Right. So what I wanted to talk about is issues to do with randomized control trials and observational studies. The randomized control trials are supposed to be the gold standard in medicine and in many other sciences. The randomized control trials are essential to evaluate the effectiveness of medications or interventions and to obtain regulatory approval for their use in clinical practice. However, RCTs lack generalizability and are not good at estimating long-term effects. This happens because of very stringent entry criteria. For instance, when patients are recruited to a clinical trial, usually investigators are trying not to include people with multimorbidities, frail elderly people, and so on. And also, it's very expensive to run randomized control trials, so they're usually pretty of short duration. For instance, 3 to 5 years would be the maximum clinical trials run for. So it's very difficult to estimate long-term effects of those randomized control trials. Observational studies fill this gap by assessing long-term effects of medications on rare outcomes, including mortality. Lately, the use of computerized health databases has led to an explosion in the number of published observational studies on the impact of medications and interventions. And of course, our research project is doing exactly the same. We are looking at the analysis of electronic health databases for actuarial research. However, in observational studies, there may be various biases which may creep into the results. Well-known biases include the so-called immortality bias and the bias by indication. So what is the immortality bias? Immortal time in observational studies is a time when the outcome cannot happen. For instance, we could look at the patients receiving an implant, say heart implant. And if we are looking at the benefits of heart implants, we won't have anyone who died before receiving an implant. Therefore, the time of those patients before receiving an implant is exactly the so-called immortal time. So, if we analyze a study without taking this into account, our results will be biased in favor of treatment. The bias by indication arises when GPs prescribe drugs to sicker people. Other self-selection biases arise when, say, better off or more well-educated people get more treatments. There is also quite an avoidable unmatched confounding, for instance, by family history, diet, exercise, and so on. Things which are just not there, are not recorded in the primary care data. In our studies, the first step which we start from is to very carefully design the study so that we can minimize this and other biases. So we take a lot of care at the design stage. You have heard about our studies on particular conditions, and also studies were so-called case control studies, which started from the date of diagnosis for treatment. Here we match controls to patients by age, sex, and GP practice. Because of this, our biases are partly eliminated by matching, because both controls and cases live roughly in the same area, have the same unmeasured confounders such as air quality, water quality, same GP, so the same quality of health service, and so on. We also eliminate biases by careful statistical modeling, which includes all available confounders which we are aware of, and also sophisticated imputation to fill missing values. Missing values is another possible source of biases. Unfortunately, missing data are unavoidable in big health databases. The problem is that the missingness can be informative, and that can create selection bias when using complete case analysis. As an example, we talked about healthier patients not going to their GP as often as sicker patients, so they would have less complete records. So if we do complete case analysis, we are ending up with sicker population than it is in reality. So we need to use appropriate multiple imputation methods to get rid of those selection biases. We use multivariate multiple imputation methods to generate usually 10 imputed data sets and then amalgamate the results of analysis of those 10 data sets using Rubin's rules. We also evaluate variability of our imputed data sets. For actuarial implementation, we spent quite a lot of time and effort trying to obtain good models. As I mentioned, we usually look at two possible designs. Either we start from fixed age, say from age 60, in our landmark analysis of statins, and we follow them up. And this is easy because then our natural time scale is just age. But in our case control studies for various chronic medical conditions, we start from diagnosis, and therefore the time scale is time from study entry. But people can have different ages at entry. People are diagnosed with particular disease at different ages. This brings some complications to further analysis. As I said, our original models use time from study entry as a time scale. But we understand that life expectancy, say, would also differ by birth cohort, and it may differ by the age of diagnosis. So we categorize the birth cohort, and we also categorize the age and diagnosis, and use them as data predictors. So this kind of models, this parameterization is useful for medical applications. However, when we talk about actuarial implementation, it's much better to have the models with continuous age. So first, we attempt to change the time scale to age, and it is possible, but the models were not interpretable. And we later understood that this happens because age at study entry is the age of diagnosis, and the survival time is not independent from the age of diagnosis. That's why we were getting biased results. So we now reverted to models with not categorical, but with continuous age of entry as a predictor. And now we use these models to obtain relative survival benefits or harms, for instance, as we heard about in the stroke and AIDS study. To summarize, the aim of our study was to develop novel statistical and actuarial methods for modeling mortality and morbidity and evaluating longevity improvement based on big data. We worked at 7 various target conditions and interventions. We developed novel methodology, either completely novel as a Double-Cox model, or we developed a method of incorporating standard statistical methods such as the Cox regression and random analysis into actuarial calculations of the life expectancy. We also have provided implementation into software such as Morbidity app, which got to be quite popular, and also the art software we're talking about. So this is it, and now I hope that we can move to the discussion and the questions. Thank you for your attention.
I hope that I'm live again. I hope that you can hear me. I invite Nigel Wright, data science for life and for healthcare issues at Aviva, to the podium. And I also invite Nicholas Steele, professor of public healthcare, to the podium, and Yelena Kulinskaya and the presenters as well. I have questions from the audience, and I will therefore kind of prioritize the questions from the audience. I have 7 questions, which means that I will sort of summarize them, bring them together, and hopefully you can answer 2-3 related questions in one go. There's questions about about the data itself, and they are they're interesting questions. I will read them off. But they are, I guess, generally questions about the reliability, the collection of the data, how you can interpret the data, how sure you are about what they say, and so forth. So let me read them off. Incidence based on primary electronic health records, is that less reliable for some conditions? For instance, stroke, where care might be hospital-based. The data where they are linked to death registry, hospital episode data, and so forth. So quite a detailed question. I have another one in the same vein. Can you expand how you approach practical challenges of working with electronic healthcare records, validating the data, censoring, identifying the period covered by these data, handling stale data? We've talked about missing data, but stale data is another one. There's a third question that I would lump in with that. The threshold for diagnosis, for instance, for type 2 diabetes mellitus, it may have changed over time. Is that something you can spot? Is that something that affects the quality of the analysis? Can you work with that? So these are quite detailed questions about the data, and I kind of lumped them together. So if you could just give your thoughts, and probably in this case, Yelena, kick off first.
Thank you very much. It's quite interesting and important questions on the data. So first of all, I wanted to say that for each of our case studies, we were carefully selected which data came into it. So in particular, we only allowed data from a time point where the practices were pretty good at registering deaths, and that happened at different times for different GP practices. And to answer another question there, we work with deaths recorded by GPs, not by OMS. But as far as we know from various publications on scene, the death registration is quite good from particular time points where we started using the data. We also only use the patient records which were registered with GPs at least for a year, which were active in a short period before we started entering people in the study. So as you said, we did not use the stale records of people who were there for ages. It's a complicated question about the quality of registration for hospital admissions, but usually GPs do get a record of their patients from the hospital. I think Nick still would be better authority of explaining how that goes on, but I hope that the fact of whether they had stroke or not is recorded well. What is not recorded well, of course, is the severity, say, of a stroke and other conditions if they were in hospital. Did I answer everything?
I will sort of pass, pass to Nick and Nigel. I mean, Nigel, you who do this, who do this for a living, data science for an actual insurer, for the balance sheet, for the underwriting, etc., for risk management and so forth. What are your thoughts on this?
Yeah, so I think that there is a little bit of an issue about severity and things like that when treatment has gone on in hospital, because what we see in the thin data set is what's entered in read codes by the GP. So the GP might have information that has been sent from the hospital, but in the form of letters, which might have much finer detail, but for anonymity reasons, that information hasn't come through in the data extract that we've got, that we've modeled in thin. Mm-hmm. So things like cancer, for example, or severity of strokes. So cancer, you might know that they've had a particular cancer, but it might not go into the level of detail that you might want to know about severity.
Thank you. Nick, is there anything, Nicholas Steele, is there anything you would like to add on these issues?
Yeah, thanks, Eric. Yeah, I mean, I agree with both Nigel and Elena on that. And just to add about electronic health records and stroke, I think I think those primary care records are probably the single most reliable source of incidence and prevalence for stroke, and their huge benefit is that they're comprehensive, so they cover the whole population. The problem obviously with hospital data is you're never quite sure that you've got good population coverage. You might be missing private patients, or with hospital episode statistics, you're picking up some private patients in NHS hospitals, or so there are people are missing. You're also not sure about travel. People might have traveled to a different hospital, so attributing hospital figures reliably to population, denominator populations is difficult. So I think for that reason, when you add in the fact that primary care does have very accurate records of stroke when it's occurred, albeit Nigel's absolutely right about the lack of severity information sometimes. But for me, in terms of prevalence and incidence, I think that the accuracy of that and the link to population data trumps the severity, certainly for the purposes of this type of work. And the other huge benefit, of course, is of using primary care records is it's linked to all the other attributes of the patient that you've got information on in primary care, which you just can't do in hospital records.
I have a question here that I would now like to field. Sensitivity of the results. How dependent are the results, in fact, on the statistical model, the statistical assumptions, or assumptions flowing into the analysis? So, is the statistics and the methodology here a tool to come to firm conclusions, or could the methodology applied potentially sort of cloud the interpretation somewhat? So sensitivity around models, assumptions, and so forth. Probably Elena first.
Well, I think that our models are quite robust. First of all, because if you look at the Cox model, which we usually start from, it is a semi-parametric model. It doesn't depend on the baseline hazard. But after that, as you heard, we do try to fit baseline hazard, which would describe the data reasonably well. We feed the baseline hazard not for comparison of survival experience of various risk subgroups, but more to be able to fit actual survival function to calculate life expectancy. So it is kind of a further part of modeling. Another thing which we do, we calibrate our obtained survival functions and life expectancy, as I mentioned, for the landmark analysis, so that our overall survival is a weighted sum of survival functions for all risk profiles. And basically, they all add up to population life expectancy. So I hope that we got it reasonably well. I'm not sure. Yes, cross-validation. We do look at cross-validation of our result, and that coefficient risk, for instance, Jabulova mentioned of 0.76 is how well our model predicts the results. And we usually get quite good goodness of fit quality in our
Can I maybe pass this question as well to Nigel, but let me add one of the other questions, mindful of time. Would employment status be a useful parameter or a useful variable in these sorts of models, Nigel?
I could sort of duck that question by talking about the age group that we've been looking at here, but that's kind of cheating to say that the key age groups that we're looking at when we're looking at the mortality experience is for older people who would generally be retired. But that's not to say that wouldn't be interested in their employment status when they were employed pre-retirement. But that's not information that we've got reliably in the thin data set. So for that sort of thing, what we've had to rely on is deprivation score data. So using the Townsend scores, I guess it's a proxy. It's not going to give all the information, but in terms of looking at socioeconomic differences, looking at the sort of score.
And then maybe I can immediately add another question. Relative risks in the research. Could these relative risks in the research be combined with a mortality table, a customized mortality table coming from elsewhere? So could you kind of lift off, I guess the relative hazards and then build the relative hazards from your work into someone else's customized mortality database, which might reflect other things accurately, in a sense? Is that something that either Nigel and Jelena would like to comment on?
I can comment on this, and this is exactly what one of our programs is doing, where you can take our hazards or hazard ratios, but you can use it with your own data set. So it will calculate the weights from your own data set. And you can also supply your own distribution, say A and B parameters for the Gompertz distribution. So it's exactly kind of using our hazard ratios with your own baseline distribution. Or you can even do the full modeling on your own using one of the other programs.
I would like to lift one more question that came from the viewers, and I would hand it to Nicholas Steele maybe. The question is, can we get the data? And so let me kind of reformulate the question. How is the availability of these data? What are sort of the terms that they are made available on, etc.? And I guess that's interesting for the UK, but it would be equally interesting for other countries. How widely accessible is this data? What are the terms, etc.?
Good question. The short answer is yes, all the data are accessible to anyone that wants them. The caveat, as long as they're prepared to pay for them, they're commercially owned. And for a variety of reasons, primary care data has been sold commercially, so you need to pay to access the data set. So there are a number of similar data sets. The two biggest ones are THIN that we used for this study and CPRD, Clinical Practice Research Data Set. They have an overlapping group of practices, but different practices return to both of them. Both of them are broadly nationally representative. Both of them are fantastic data sets for population level healthcare, and they're really unique in the world. We have this great resource of primary care data that covers the whole population. So they're a wonderful resource, which is why the custodians of the data can charge a lot of money, particularly to commercial providers, for accessing them. But even for non-commercial research use, there is a substantial cost for accessing the data sets. There are, however, a number of other providers, usually with smaller data sets that might not have the same size of national coverage and national profile, but a number of people moving into that space and offering access to healthcare records on a local or selected national basis at cheaper, not at commercial rates, at cheaper costs, particularly for research purposes.
Okay, time is going on, and so I will attempt to finish on time, but I think I have sort of a double question, which I will ask for the medical bit to Nicholas and for the actuarial bit to Nigel, I think. And so this study, what does it change? That's actually the question. Is there scope here to change treatment guidelines, such as the National Institute for Clinical Excellence gives? And is there things that we have to change in actuarial practice? So let me ask the medical question to Nicholas Steele and then pass for a final word to Nigel Wright on the actuarial practice. So what changes now that we understand these issues better?
Yes, I think to answer in general terms about using a big observational data set like this, what does that add in rather than the usual randomized controlled trials that national guideline producing bodies like National Institute for Clinical Excellence in this country rely upon for lots of reasons around RCTs being considered gold standard. So what does an observational data set add? And Elena touched on this, that essentially it's much more representative of the full range of the population rather than just a highly selected group that have been selected for entry into a clinical trial. And it's just not practical. It's not possible to follow up people in a randomized controlled trial because they've lost a follow-up for more than 5 years, absolute max really, before you start getting a very odd follow-up group that you're still in touch with. So observational data sets can give you this wonderful long follow-up time. So those are the big advantages, and we can only use that. If I take, I know we're short of time, so I'll just briefly mention diabetes, statins as an example. And if we think about what the sort of gaps that we filled in the knowledge about statins, so they're probably the most researched topic in medicine. There's been so many randomized controlled trials of statins, and yet we still weren't sure about the effect in the over 75s because there've been relatively few older people in the statins trials. And we still weren't sure in a real sample what level of risk threshold, which is the algorithm some people will be familiar with, is QRisk2, which gives you your risk. You can put QRisk2, well, it's now QRisk3 actually, into Google, and it'll come up with an algorithm, and you just type in your some information, and it gives you your risk of a cardiac event in the next 10 years. And NICE has recently reduced their risk threshold from 20% to 10%, at which you should be seriously considering taking a statin. And I think our data has said that actually we've not seen any benefit in the real world for people with a risk of 10%. In between 10 and 20, there might be some benefit, but nothing much. It's not really till you're over 20% that you get a benefit. So I think that's a really important finding. And the other key thing that we've been able to do is have lots of older people in the study, and we've shown this really interesting finding that the benefits increase. The older you are, the more benefit you're getting, which fills that gap of information around what are the benefits for older people.
So we'll definitely hear more about it in terms of clinical excellence. Nigel, in terms of actuarial practice, how has this research changed how you think about actuarial practice?
Well, I know that we're kind of running out of time.
Yes.
You give an enormous answer to this question, but it's basically, so as actuaries, we're trying to understand longevity risk for many different reasons. And this helps with our understanding of longevity risk. So it'll help with understanding heterogeneity of populations and subpopulations. So if you're looking at population data and thinking, how does that change my view about my subpopulation, if you're looking at pension scheme or looking at a subpopulation of annuitants, allowing for differences there. If you're looking at mortality improvements over time, so a lot of the research that we've got here is kind of showing where mortality improvements have come from and helping to understand that. I mean, this is never going to be the only source of information you're going to look to, but it's going to supplement all the other sources of information. And so it will help you with questions about, say, if you're saying mortality improvements of part of that is down to statins, how much more improvement can you get from higher levels of statin prescription, that sort of thing. I mean, for underwriting annuitants, I mean, I can go on, but what I recommend is get the slides and have a look at the information, and then look at the the references in there and kind of have a look at where you think that it can help your particular area of interest, really.
Thank you very much indeed. So thank you, Nigel Wright. Thank you, Nicholas Steele. Thank you, Elena Kulinskaya, and the researchers from the University of East Anglia for this brilliant webinar. Rounding out, I would point out that there's also a longevity app that has been launched by the University of East Anglia, which allows you to fill in particular medical medical features of yourself or somebody you're interested in to get an improved longevity estimation. We've seen the R-Shiny application from Njabolo and Kube, which will be made available, and also the package of art tools on GitHub. So there will be things that you can download, use. We will distribute both this video if you want to see it again, or and distribute the slides. The questions in the chat have all been answered that I am aware of. This, of course, qualifies for CPD, so your professional development. You can take this, attending this webinar down as qualifying expertise that you've developed. We will also send out a feedback survey. So please, if you can find time to send, to fill out the feedback survey that we will send to the email that you register with. Thank you very much indeed for doing this. I hope you have enjoyed, but also picked something up in this seminar. Thank you very much for attending it, and I wish you a good afternoon. Bye-bye.